Hi everyone. I'm Thilina Bandara, assistant professor at the School of Public Health and the president of the Saskatchewan Public Health Association. Really excited to get our Pop Health Out Loud series kicked off this year with some work around the COVID-19 pandemic and some engagement we did with some local public health officers across the country. I'll hand it over to Chuck.
Hi, I'm Chuck Plante. I'm a research scientist with the Saskatchewan Health Authority in the research department. But when I worked on Thilina or worked with Thilina on this work, I was doing this as previously a research officer for the Urban Public Health Network, and then as a postdoc at Johnson Shoema Graduate School of Public Policy. And then I'm also a board member of Saskatchewan Public Health Association.
Excellent. So let's get right into it. So this is a paper that if anyone who's interested can find. It's published in the Canadian Journal of Public Health around some work we did around 2021, 2022 to understand the enablers and barriers to public health practice during COVID-19. This is just a list of the authors here. Folks that have worked with the Urban Public Health Network in the University of Saskatchewan, as well as the School of Public Health and the Department of Community Health and Epidemiology. And so just to give a little bit of a overview of what the Urban Public Health Network is, the Urban Public Health Network is a member-based nonprofit. You can go find the website at www.uphn.ca. The membership is made up of 23 of senior medical health officers from 23 large cities across the country in urban settings. So the membership ranges from coast to coast. And like I mentioned, they're all local medical officers of health, so they're all medical leads of their particular jurisdictions. The president is Dr. Corey Neudorf, who is at a professor in the School of in Department of Community Health and Epidemiology. And so this is a nonprofit that came together in the 2000s, early 2000s, to share public health insights from across the country from a local perspective. And starting in 2020, Chuck and I worked to scale the research efforts of this organization, given they have a particular keen line of sight on what's happening at the local level. And so they were particularly our subjects in this research. So just to give an introduction about the research itself. What we do know is that local public health units played a crucial role in mitigating COVID-19. The local units, so that's what LPHU stand for, the local public health units, often adapted federal and provincial guidelines to fit the local needs. So many of you might be familiar with the guidelines that were talked about in the news and such. A lot of those which were reported were at the federal level and the provincial level. But to really make those things applicable at the local level, local medical health officers had more or less authority, given where you were across the country, to synthesize that provincial guidelines and adapt it for their sub-provincial levels. Our study investigates the enablers and barriers faced by these local medical health officers in doing their job during the first 2 years of the pandemic. So the objective of the study is to understand the factors that enabled or hindered local public health efforts. We use the consolidated framework for implementation research, which I'll talk a little bit about in a little bit here, to sort of organize our findings. And we focused on governance, human resources, and the pandemic, the complexity of the pandemic. This was a part of a research effort where many questions were asked, but we really focused on the enablers and barriers questions. We had 26 semi-structured interviews with local public health leadership. The participants were recruited from 126 LPHUs across the country, and like I said, they were longer interviews. We just used a subsection to answer this specific question, and thematic analysis was used to identify the enablers and barriers from those specific questions. This is just a breakdown of where the representation of medical health officers across the country in our sample. So 20, like I mentioned, we had 26 interviews from 7 provinces representing about 55% of the Canadian population. These medical health officers are usually in charge of a pretty large population's public health services. And so our sample represents a pretty large proportion of that across the country. And our medical health officers came from a mix of urban, rural, and medium-sized jurisdictions. Like I mentioned, the Urban Public Health Network represents the urban medical health officers, but we had a partnership with the Public Health Physicians of Canada to reach out to semi-urban or more rural regions and to get in contact with those medical health officers. And so in the second column, you can see sort of what type of community our medical health officers were representing. And this is all in the paper too, as well. A little bit about the Consolidated Framework for Implementation Research. CFIR has 4 main buckets of concepts. It's sort of 4 constructs that it uses to describe public health or any intervention overall. And so what we wanted to do was, synthesize what the medical health officers were telling us and put those findings into these 4 buckets. And some of the 4 buckets is like what we wanted to see is what were they mentioning in terms of the inner settings of their public health units? So facilitators and barriers that pertain to organizational structures and processes. Did they mention anything about outer settings? So things that were outside of the public health jurisdiction that were affecting their work. So this is broader system level influences from the health authority or governments, or what were some externalities and how was that affecting their work? A little bit about the process, so the implementation strategies and the collaboration in actually doing their work, and if they mention anything about the interventions themselves. And so I have a figure showing how our findings fit into these constructs. So I'll go through 3 enablers and three key enablers and three key barriers that came out of our study. Number one, so when we're trying to understand sort of what helped local public health unit do their work, one big enabler that came out was the massive amount of resources that they were afforded during the pandemic. There was significant funding from provincial and federal levels and an increased access to human resources and equipment. And so I added a little bit of a quote that also shows up in the paper, just speaking to this, talking about, the province. In this particular participant talked about the province and the blank check that they were provided and how that sort of unlocked their ability to access more human resources and equipment.
On all Canadian imports into the United States. So
Um,
a lot of variables here.
so the second enabler here we talk about is buy-in. So buy-in was mentioned a lot as a enabler for them for local medical health officers to do their work. They talked about the internal staff of their organizations having dedication and adaptability, which this was including staff, including nurses, nurse managers, health promotion people, everyone that's employed under public health really showed a high level of buy-in. And external support from government and healthcare providers really helped in that help public health do the massive amount of work that was needed during the pandemic. This is a quote here about how this is a medical health officer mentioning how, I'm astounded at how my staff developed skills beyond what we thought they had, and they met the challenge. They became better professionals. Uh, Another particular key enabler that was mentioned was collaboration and trust. And so there was you know, as we sort of retrospectively look back at the efforts that were done in public health, it was clear that public health alone couldn't have accomplished all that needed to be done. And, it's evident that collaboration with, partnerships across different organizations really strengthened the efforts, and coordination across public health hospitals and municipalities, you know, made sure that there wasn't, wasted efforts and everyone was sort of rowing in the same direction. And so this was probably the most salient enabler, given the massive amount of complexity and intersectoral issues that needed to be solved during the pandemic. And this has borne itself in research henceforth around how important partnerships across different organizations were and continue to be when dealing with large public health issues. When discussing barriers, one of the key barriers was the human resource capacity issues. Even though there was money and a lot of resources afforded for public health to staff up, there was a shortage of skilled public health professionals to actually bring into these organizations. And the increased workload led to staff burnout. And so just, this idea of needing to surge their capacity, for just finding the people that were required to increase the amount of output public health did was a struggle, as well as the massive amount of work that was put on those folks that were in public health. Number two, governance confusion. So this is not anything new to anyone who has looked at any problem when it comes to, especially in the Canadian context, given our federalist system. We often are, organizations often confused at many times about who's in charge of what necessarily. Is it the feds? Is it the province? Is it the local level? There were unclear roles and jurisdictional conflicts when it came to actually doing the work in public health. And there was mixed messaging from different authorities at different levels out to the public. They talk about the federal, provincial being divided, and it can get tricky when there's so many different players involved. Role clarity really gets mixed up when people are confused about who's in charge and of what particular aspect of the pandemic management. And then thirdly, the managing complexity. So, the COVID-19 pandemic was just particularly complex as a problem to solve for public health. It was a rapidly evolving pandemic with scientific uncertainties. And then when it came to the complex implementation efforts, for example, like a vaccine supply chain disruptions and all these different pieces of a process, of different processes, being contingent on other different processes, it was just a very large amount of uncertainty. Uncertainty about policy, about responses, uncertainty around resources, and the virus too. Uncertainty of what to do next and how to do it. A lot of these public health units were having to make decisions before all the information was out, and that's just a pretty standard type of response when you're dealing with complex issues. And so how this all fit into the CFIR framework, you can see here I've labeled everything that is a barrier in red and where it fits into the four domains of CFIR. So, in terms of resources were both an enabler and a barrier across internal and external. So there was a lot of external resources coming in, but there was a sort of a dearth of internal resources actually being able to be capitalized on. They reported internal and external buy-in from both inside the public health unit and outside the public health unit. Collaboration was a enabler, across organizations, as well as feeding into how well the process of actually doing the work. That's why it sort of spans between these two domains. Governance confusion really messed with the process of how public health units sort of prioritized what kind of work to do. And in terms of the intervention, the complexity of the whole issue really hindered the efforts of putting forward interventions in the most efficient or an effective way.